I have two people here that I respect very much, Darren Vaughn, who is a physician assistant, and Diana Hunter, who is an advanced nurse practitioner. And I'll let you want to give your own biography?
Sure.
Yeah.
Yeah, so all you guys are interested in healthcare here. He said something very interesting out there that I was going to start with as well, is that you're going to find, you know, and probably all of you guys can kind of relate to this, growing up as a little kid, you kind of think you want to do this, and then you think you might want to do this, and eventually things kind of round off and become more clear to you. I look at it as like life's just a journey, and you just kind of get on different train posts, get on, get off, and each time you kind of change directions of wherever God wants to send you. But if you have, my sense of it is, with the calling and the gift, it's there, and you'll eventually find it, and you'll have a heart and a passion for it. And I never knew about a PA. I never knew what a PA was until I joined the military. Even in the military, when I first got introduced to a PA, I didn't even know what that meant. And probably the first couple of times that I found myself involved with one, I didn't even know that's what they were. Until later on, I found out that that's what they were. So I think the flexibility of understanding that you think you may know what you want to do now, but then eventually you'll kind of clarify that in the future is something that's going to be true for most people. It was clearly true for me. I first started off wanting to be a vet. And then, because I loved animals back then, you know, as a elementary school person. Then, as I got into my middle school years, I got into health and fitness and working out and wanting to be a bodybuilder and things of that nature, and really thought I was going to be interested in physiology and sports medicine and that type of deal. And you could kind of see the kind of theme I had interest, but they kind of always seemed to go towards the biological side of things. So that's what I'm kind of saying. There's a theme that I think if you just kind of follow what your heart and passion is, you'll always kind of know what you want to do. So my story was growing up in Bedford, growing up in a family that really didn't have much financial means. Nobody had gone to college before. I had interest in college and I wanted to do it, and just like you guys, I was really focusing once I got to high school of trying to do so, you know, and keeping grades up and things of that nature. But I didn't really have a foundation of background, of mentoring type thing like that, so just did the best I can. And then something happened. I got to senior year and realized I didn't have any money for college, and I kind of got a little bit, I don't know if we could say depressed about it, but I just kind of like had the senioritis type attitude and just said, well, you know, I got all my credits I need, but I don't know how I'm going to go to college, so I just kind of gave up on it. Long story short, ended up in the Navy, a place that I thought I would never go, and so I joined the Navy, and the day I went there for the recruiter, they had to take an aptitude test. You take the test, you find out that you had certain things that they kind of, those tests I guess are pretty accurate because they kind of leaned me into, she told me, you should be a hospital corpsman. I was like, what's that? She said, oh, you know, like medic, like on MASH. And I was like, oh, okay. So I eventually joined the military, got through the hospital corpsman training. And I think that's when I first kind of met the first kind of PAs, but again, I didn't know what they were. Ended up being with the Marines because we are their hospital support staff. And during that time, my roommate had a book that he was looking at, and it was a book on PA programs. And so I grabbed it from him, looked at it, like, what is this? And I looked through it, and then found out that there was PA programs in Ohio. And I looked at it, and at the time there was only 3. And there was one in Toledo, I think one in, I forget what the other one was, and then one at Tri-C up in Cleveland. I was like, oh, that's my hometown. So that was like September of the year before I was getting out. I came home at Christmas break, talked to the people at the program, gave them my information, came to an information session, and when I got out the next year, started the process of getting all the prereqs done and getting to the program. I graduated in '94 and got my first job as a PA in family practice. Worked family practice and internal medicine for the first few years, and then ended up coming back to the program as a clinical instructor. One of the things that I found out about myself as well is I love teaching. That's something I found out when I was still in the Navy, because I was one of the guys that always trained the other corpsmen as they came in. So education, teaching, training other people, and even in a sense like this, is just kind of a mentoring type process. Right now, I even have students come and shadow me from either high school, they're just interested in PAs, or they're in a lot of students that come from colleges already, getting ready to become a PA or get accepted to the program. They come and shadow, and then I have some PA students. So I always like to have people come around, and if any of you guys just have time and you just want to come and watch and see what we actually do, because I think that's another part of it, because a lot of times you think you know what you want to do, and exposure will kind of give you the idea whether you do or you don't, because some people might feel they want to get into something and then they actually do it and realize they don't want to do it. So that's a good thing about being where you guys are at, because you can actually have time to kind of roll with the flow and figure out exactly what it is that you want to do, and you have time to experiment and explore. I had a young girl just a couple weeks ago shadow me. She was a Mount Union student who was a biology major, and she's applying for the PA programs now, and she's already trying to decide what she wants to do once she graduates from the PA program. I was like, chill out, just become a PA first. You'll get through that process as you become as you get into the program and go through your clinicals. You don't have to decide exactly what you want to do yet. So in any event, I think, how many people have heard about physician assistants before? Okay, all right. So one of the things that becomes very confusing for some people is exactly what it is that we do in the whole process. Basically, some people like the term, some people don't. Mid-level practitioners, both nurse practitioners, which Diana is, a clinical nurse specialist, and physician assistants, very similar. We basically, the thing I like about what we do is we are able to work along with the physician and work along with the patients. We are autonomous in the sense that we can make the clinical decision making and kind of guide the course and direction of the patient and the patient's care and outcome independently, but with supervision. So you are able to make a decision and make a choice about what you think you should do for that patient. And it's all about helping people, because I think whether you like science, biology, all of these other things is one thing, but if you don't have good people skills, or if you don't like people, you're going to be frustrated. So again, that's one of those things that only time is going to tell whether this is something that you're going to want to do, because you're really going to want to help people, because I can guarantee you, Dr. Kingsbury knows it and Diana knows it, people are people and they can be frustrating. And sick people can be even more frustrated because they can be short. And so you have to learn how to be able to have the right temperament to deal with people who are sick and suffering and even want to help. So if your first desire is not to help people out, you're probably not going to do good in this area of medicine and healthcare. So PAs are what we do is broad and is diverse, and one of the things that I put down is the flexibility of a physician assistant. That's just, to me, one of the things that I liked about it. I kind of found that out when I was in the Navy, that you had to be flexible, because the short time that I worked at the Battalion A station with the Marines, in that year and a half, I had 3 different supervising docs. Because in the military, there was people that come in, they stay for a while, then they get shipped off to another place. And working sick call, I was one of the sick call PAs taking care of the Marines, and I had 3 different doctors. And I noticed just during that time period, all the doctors did something different. They all was a little bit different, and they approached the same situation, and they would do something different. And right then, I learned that you have to be flexible, because if you're going to be a physician assistant, you're going to have to be able to kind of be a little bit malleable as far as working with the doctors that's supervising you. And today, I have 3 different doctors that I work with in the group that I'm with, and they all do things differently. So you have to be flexible to understand that they're the physician, you're the assistant, you're working with them, you're helping them out, you're helping with the patients too. And then you guys got to figure out how to be flexible enough to understand that medicine is truly an art. It's a science, but it's an art too, and everybody can do, there's some flexibility there. So you can't be like just stuck in a concrete block and thinking that everything has to be the same. So the flexibility is also in that our training is general, primary training for general medicine. And Diana can speak a little bit more on nurse practitioners and clinical nurse specialists, but from what our training is that we can flex between different things. So we can, as you graduate, I can go and work for a surgeon, I can go and work for a cardiologist, I can go and work for GI like I am now, I can go and work for primary care. So the flexibility that our training gives us is that we have a generalized medical specialty, and then we can go and specialize wherever we want. And all it has to do with is once you graduate to whatever state you graduate, I mean whatever state you go and work in, you make that supervisory agreement with the physician that you're with, and then you are set up with that state, and they'll allow you to do whatever that doctor wants to grant you to do. And so there's a lot of flexibility in that. So
Darren,
yeah.
how long was you graduated in '94 from Tri-C? How long was that program?
So I took 2 years to do the prereqs and get everything out the way, and then the program is 2 years.
So it's 2 and 2?
Yeah, well, no, that was mine. So and that's what I was going to bring up about the flexibility too. PA education. I looked this up last night because I didn't know. This is a 2015 stats. Today, there's only 1.7% of the programs that are still associate's degree. That's just what I had. At that time, the majority of the PA programs were bachelors. It was associates and bachelors. But the way they set it up, the accrediting board started in 1975. PA started in '68. The accreditation nationally was in '75. And at '75, they didn't care what the end degree was. It was just that every program had to be set up with the same standards. So here was the standards that every program had, and it didn't matter if the end terminal degree was associates, a bachelor's, or a master's. At that time, very few of them were actually masters. That transition has changed. Everything has changed now. Now if you look, probably about 90% of them are all masters, probably about 10% bachelor programs, and very few, if any. I don't even know how many associate degree programs are left.
So how many years?
So what happens, like today, like the girl I just had shadow me now, she is a Mount Union student in biology, and she wants to become a PA. Now she was a senior. She's graduating this year. She's now applying for all the PA programs nationwide. You can do it a couple ways.
I mean, if she applies for those programs, how long?
It's 2 years. Okay. Yes, that's what I was going to say. So once you apply, so all programs are 2 years, no matter which ones you have. But the difference is before it could have been a 2-year associate's degree. Now you get a bachelor's and then 2 years master's. The program that I went to, Tri-C, about 5 years ago, merged with Cleveland State, and so now Cleveland State and Tri-C co-op together, and you still get a bachelor's through. You get your associate's PA through and then you get the master's through Cleveland State. So, but all programs nationwide are 2 years, no matter what. So, after you graduate, you take I forget how many. I think it's a 600 question board. It takes about 5 hours to do. I think they give you 3 times to pass it. And then after that, you have to get CMEs, which is the same CMEs that physicians have to get. And we have to maintain our certification 2 ways. Every 2 years, you have to get 100 CMEs and certify and turn them in. And then every 6 years, we have to take another board exam. The board exam is, I think, about 400 questions every 6 years.
Can you give them an example of what you do when you're in the office?
Yeah, so when I was
in the hospital,
when I was in primary care, family practice, it was just that. We came in and we just saw the first job I had. It was from cradle to grave, basically. You had newborns, you had pediatrics, you had young kids, and then family. So it was everything from the beginning to end. We saw everything from high blood pressure, diabetes, just basic medical care, hypertension. And that was the office setting, so we came in, and what I did was I saw all the patients, decided what was going on, what the treatment would be, kind of collaborated with the doctor and decide what we were going to do and set the plan for. Now I work, for the last 12 years I've been with GI here in the Canton area. Me and Diana work together. Diana is primarily office-based. I work in the office and the hospital. Matter of fact, I was in the hospital today, and that's probably my page was saying I got another patient to go see. And what we do is, in the hospital, we see all new consults. So anybody come in with a GI bleed or pancreatitis or diarrhea, vomiting, abdominal pain, any of the gastroenterology type things, they call us, and then I go see the patient, decide what's wrong with them, what test to order, what to do, what's the next step, order those things, interpret those things, and then decide what the next step is. Sometimes we have to set up for the doctors to do a scope. Sometimes we order imaging, CAT scans, ultrasounds, whatever, and kind of decide what to do from those. And then some of those patients become our patients that we follow forever. Some of them don't. We just kind of take care of that current problem and maybe not see them again. In the office, our current patients that we see on a regular basis, all those things I just said, plus pancreatitis, chronic pancreatitis, hepatitis A, C, all of the different ones, and we treat, and we see them on a regular basis, and each patient problem is different, and each patient is different. We might see some, we're not family practice, but a lot of the things that we see, especially if we're given medicines that we have to monitor, blood work, things, we see our people minimum of once a year, some people every 4 months. It just depends on what the problem is. When they come in, we decide if there's a change that needs to be made in their medications, if we need to do something different, order new tests, refer them to somebody else. Sometimes we're a subspecialty as gastroenterology, hepatology, but sometimes we have to send them to subspecialties. So we have to send them to Cleveland Clinic for different things that we don't do down here. So it's a lot of medical decision making that has to be employed as a PA. And that's the other thing about what I love about doing what we do, is that you actually make decisions. And that's another thing. Some people might not be comfortable with making decisions. So being in healthcare, you have to be comfortable enough to have confidence that you know enough. And here's one thing that I always tell my students, and I try to live by myself: know what you know what you don't know, and know when to refer. I think as long as you have a healthy understanding of what your knowledge base is, and when you need to ask questions and when you need to refer them to somebody else, whether that's making sure you go over something with your primary care doctor. But I even think not your primary supervising physician, I even think primary care doctors operate that way. They know what their level is and what they can do, and then they know when they need to refer to somebody else. And as a PA, under the system that we have, that's what we should do too. Any questions? Has anybody thought about being a physician assistant or checking them out? Okay. Had you followed up with anybody yet? Okay, you can always come and shadow me.
Yeah, and you'll see a lot because that's a very large practice.
Yeah.
Most of the times, you know what Dr. Fahmy or the other doctors would do. For instance, if belly pain, a gallbladder, you're going to get blood work, ultrasound. You know that. If there's any question of what to do next, then obviously you're going to be talking to the physician. But what about medications? What kind of leeway do you have in the office or hospital with medications and IVs and antibiotics?
Okay, so with mine, I did not, since I don't have a master's degree, Ohio didn't always have PAs with medications privileges. That happened about 5 years ago. So I chose not to go that direction. So what I have to do is have everything filtered back to them, and as long as they give the approval, then they'll go ahead and agree with that, and they can go ahead and prescribe it at that time.
How do they find out?
I send everything directly to them.
By text?
Or through our computer system.
Okay.
Yeah. In the hospital, they just co-sign it.
Yeah.
Yeah. So, any questions?
I was just going to make a comment that I find that the physician's assistants sometimes are much more thorough and caring and go in depth versus the doctors.
You know, I was going to say something about that.
You mean they listen?
Yeah, I was going to say something about that. Here's the thing, and I put that down on my bottom, and I forgot to mention that. I look at it as a patient advocate. You know, that's another word for PA, patient advocate, and patient education. And the reason, and it's probably because, you know, I'm simple. So I can break things down, and I use this all the time. I use basic things either from around the house, from gardening, from cooking, whatever I can think of that people can understand at a level, I'm going to explain it to them at a level they can understand. And it is about being sensitive enough to take the time to listen to what they're saying, hear what they're saying, and then, again, advocate for them. And we see ourselves, and Diana could probably say the same thing for her, as a intermediate between the patient and the doctor, because sometimes, because of the way healthcare is, the time and the schedule is not conducive for people to spend a lot of time with them. But what I try to do is make sure that I do listen to some of the things that they're saying, and if I can pick out something that they're saying I can tell they're concerned about, I'm going to address that, because I know if they leave just as confused as they were when they came in, then I didn't do a job. So listen to what the patient has to say, and then advocating for what their needs are, and then communicating that back to the doctor is part of what we do. And then what I try to do is education, try to break things down to a point where they can understand it. And I found that when you can tell somebody something and make them understand it, the light comes on, and then they got it. And to me, I don't have any proof behind this, but I think it increases compliance. Because if you don't understand why you're taking something, you're not going to take it. I just know people. And so I try to do my best job to explain to them what's wrong with them and why they need to do this and why they need to follow up. And I think that does increase. It decreases fear and anxiety and increases compliance. Yes?
So I work in the doctor's office, and we see a lot of students coming all the time. They're working to be a physician assistant.
Yeah.
So are they just going into primary care, or?
Yes. So as a student, again, I think that's one of those things. Like, I will give you an example. I do believe you have a heart and a passion for things, and you kind of know what you want. So I think that's most people. I started out with a heart and passion for primary care, and that's what I did initially. And then I just kind of stumbled across this job. But I kind of see this job still as primary care, just like I said, because I try to make sure I'm listening to all the things that's going on with them. And even if it's something that I don't specifically handle, I make sure I funnel it back to them. To answer your question, I think students shouldn't look into it as, even if they know they love orthopedics. That's the beauty of PA, because in PA program, what we do is after the first year, we take you through the didactics. The second year, you get introduced and exposed to different things. So you'll do a six-week rotation with cardiology. You do a 6-week rotation with OBGYN or pediatrics. So we try to get you through all the different areas, and you might start off thinking you like something else, and then because of the schooling, you might come out saying, you know what, I really think I like this. And so you don't have to have your heart set on any particular specialty. That's why I was saying at the beginning of the flexibility of being a PA, is that you have opportunity to go in between different areas as a student in the training, but also once you graduate. Now, if your heart really, really, really is for women's health, for example, you're not going to change your mind, but you're still going to get that experience and exposure to other things before you finalize and get into that. Yes?
What's like the average salary?
You can look that up. No, I'm just playing. Just like everything else, inflation goes up, salaries go up, healthcare costs go up, so everything goes up. I think I was looking at the thing yesterday, and I think maybe beginning salaries may be in the 80s. I think the mean is probably in the mid-90s or something like that, or low 90s. But it depends on where you're at. If you're in Texas or you're in California and you're in New York, they're higher. So, and it depends on if you're working for an orthopedic surgeon, down in Texas, there might be a PA down there making $120,000. It's hard, it's hard to say. So when you talk about, again, that's kind of always started off by mentioning this. You got to know this is your heart, your passion. You got to know that you can put up with people, their people and their people, so families. So if you go into pediatrics, who are you dealing with? Mom and dad. Can you deal with that? Do you have the personality type that you can deal with people crying all the time and anxiety? It's not always that picture perfect setting that you think. Because in healthcare, and I don't know if anybody else mentioned this coming in, but I know for a fact, it's almost like talk about marriage when you have a 7-year itch they talk about. In healthcare, I noticed this about nursing, about a lot of things. People start off and they're excited and motivated, and then by year 6 and 7 they start getting burnt out. So you got to really make sure that you love to do what you're doing when you get into it, and the money becomes a secondary thing. So make sure that it's something that you really love, you have a passion for, and then that's a good question, because I actually put this down. The other thing is fulfillment. So what's fulfillment for you? Is fulfillment the money? obviously you want to make money. I always tell people nobody does anything without trying to make money, because a lot of people rail against the pharmaceutical industry, a lot of people rail against other industries and stuff, and say they're just in it for the money. Well, you wouldn't be doing what you're doing for free neither. So nobody's in it for doing nothing, making nothing. But the bottom line is, you do want to be fulfilled. But is fulfillment only money, or is it fulfillment, again, your God-given gifts, talents, being used, helping other people, fulfilling those things. Again, mine is, helping a person understand. When I really get, when that light bulb comes on and people understand what the deal is, and they start helping themselves to feel better, that's when you know you've done something good. So it's satisfaction in knowing that you're helping people out to me. Anything else?
Yeah, I was curious how many docs are in the practice that you're part of?
So,
and second question, you mentioned kind of the idiosyncrasies of docs. Do you work with all
yes.
the docs or just one or two? Or?
I work with 3. It's very interesting. Again, my personal experience was I figured that out when I was still a 23-year-old in the Navy, or 22-year-old in the Navy working for different doctors, and I figured it out before I got out. So that was the one benefit that I loved about being a hospital corpsman, is that I was being able to experience and experience it, and that's the one thing that I really clicked that I'm going to have to get used to. First, then once I found out what a PA was, because I didn't even know what a PA was, once I knew that that's what I wanted to do, and I knew that I was going to be under the supervision of physicians, I knew I'm going to have to be able to be moldable and be able to kind of flexible, personality-wise, but also when there's more than one person and each of them do something different, you just got to roll with it and figure things out how you. And what I've kind of done is kind of cut through the middle. Like when I know I'm on and I know I'm on with this person, I know what they want to do, and this person probably would do something different. I've kind of merged all of those things together, and I just do what I feel was right. And then they can add or take away whatever they want to do as well, because I've been doing this for 12 years now. So I kind of know, okay, this guy's going to want to do this, so sometimes I'll just do it the way that I know that they want to do it. But then other times, I just do what I feel is right. So it just depends. So there's definitely some flexibility there. Anything else?
Yeah, and if you want to get back to the hospital, we can turn things over to Diana here.
Okay. No, I'm not going back today. Whoever this is, they can wait till tomorrow.
Okay. All right, well, anyway, you're welcome to stay, but I'd like to give Diana time to talk about the nurse practitioner. She's it's called GHSI, Gastroenterology and Hepatology Specialist, and that means all of GI and with special interest also in hepatitis or liver disease, which is a real big deal today because of hepatitis C as well as alcoholic disease and viral disease. And she's a very, very big help, and I know I've talked to a lot of patients that have had Darren and Diana, and they're very, very satisfied. So,
it's just kind of interesting because I was you many years ago. That's how I came about being a nurse. Mercy at that time had something called an Explorers Post for medical people interested in medicine. And it was kind of fun because we did a lot of things like disaster drills, and we were the subjects, and it just exposed us to a lot of things in the healthcare field that we could look at as a possible career. So that's kind of what started me becoming interested in the healthcare, along with my mother and my grandmother being a nurse. So I initially started out as a nurse. I went 4 years to Kent State. I graduated back in 1983, so I've been a nurse for over 33 years or so. And my love at the time was critical care. I have been an emergency room nurse, the director of emergency room. I've been in ICUs, CCUs, and that's really where I loved working. But as time went on, I don't know whether it was my 7-year itch or what it was, but I actually felt like I needed to keep advancing it. And even to this day, I am always advancing my career, always. So I have plans in the future to even do more things. But we did go back. At that time, I had raised a family. So I was able to work full-time and support my family and provide a means of income, be able to pay. As I did my undergraduate, I worked at Mercy's pharmacy on the night shift. So I did Friday, Saturday, and Sunday, midnight, 12 hours, and then would trek up to Kent State and do my undergrad studies. And so I was blessed to walk out of that school without owing a bill, which I know is very hard to do nowadays. And so I kind of always worked along my career path in order to pay for my advancement. So I guess I got interested in going on to be a nurse practitioner. There was, in the hospital that I worked at, it was a rural setting, and there really wasn't any advanced practice nurses. But I wanted to do more or bigger things at that time, so I started exploring what I could do. I even kind of entertained the idea of going back to med school. In the state of Ohio, there are 4 branches for advanced practice nurses to go to. Nurse anesthetist, which you know, is one branch, nurse midwives, and then there is the nurse practitioners, and I am a clinical nurse specialist. So I chose the clinical nurse specialist because I was always raised and loved the hospital setting, which is odd because that's not what I'm doing now. But I always saw myself associated with in-hospital patients and taking care of that type of patient. But when I went to the clinical nurse specialist track, it was almost like a teach yourself program to advance. So it enabled me, and we were such a small group, we even taught each other. So at Kent State, I think there was 8 in our group. In the nurse practitioner group, there was over 60 or 75. They were, and we took some of the same classes they did. We took the pharmacology, we took the human anatomy, the whole thing. But we actually were required to prepare and teach our own lectures, so we were kind of more on the teaching level. When I chose to leave that nurse practitioner program, my goal was to set up a program for the small rural hospital that I was working at that time. Hospitalists were new at that time. What hospitalists are is a way for the hospitalists to control them, I guess, the hospital stay of the patients so they don't overexpend, they can control their spending. So nowadays, when you go into a hospital, you may not have your primary doctor that you're used to going in and seeing. You'll be assigned to part of the hospitalist team, and that person will guide you through the hospital, farming out to specialties if you need. If you're a GI bleed, you'll be consulted with us. But what I was doing at that time was a little different. We decided to do a hospitalist team based on nurse practitioners. And that way, the primary doctors in our community could still keep in touch with their patients. So what I would do was, as that patient would be coming into the hospital, your doctor was over at the office working on other patients, I would go ahead and get you set up, bring you in, do your history and physical, start the testing, get the diagnosis rolling, and get the treatment plan. At the end of the day, that physician tied up his office, he would come over and make rounds with us, and it was very quick and easy for him. It has later evolved to such more of a physician-driven thing. But at this time, there's a lot of exciting things happening in the nurse practitioner realm, I guess I'd say. We are not governed by the medical board. We are governed by the State Board of Nursing. We have in other states full capacity to see patients without having physician supervision. Ohio is a little bit lagging. At this time, the Ohio State Board of Nursing, which I just came from their meeting this week, and they are pushing us to go ahead and get more autonomous. So whether we'll be seeing that in the future, I don't know. We also have prescriptive privileges. So there's so much you can do as a nurse practitioner. You don't always have to do hospital. You don't always have to do office settings. My evening kind of job that I do right now is I take care of 3 nursing homes. So I'm on call for those patients. The physicians do. The medical staff of that facility kind of oversees us at this time, but they call me day and night with patients that are having problems. So in the future, I think that they're going to push for nurse practitioners to have a doctorate level in order to practice independently. Texas right now is, you can have an MS, MSN and practice independently, but not in this state. You can enter the VA system, and you can travel between states without being tied to any state board of nursing and be federally ruled, and so you have a much more autonomous role in the VA system if you would choose to go that way. You can do research. You don't have to have involvement with patient care directly. You can do education, which is something else that I did for a little while. As I was finishing up my program just to kind of lighten my load, and I worked in the education department, and I provided the education for new nurses coming in to the hospital. I have the ability to teach ACLS and CPR, which I still do for a lot of area clinics in this area. So I think there's a little bit more that you can do, and you don't have to do it all at once. You know, that was why I chose the nursing track, because I could still support my family, get my degree, move up the next time, and it just flowed naturally. I love what I do. There are days that I go home after 18 hours sometimes because I'm tied up going back to the nursing homes, but I get up the next morning and I enjoy what I do. Could use a little more sleep, but.
Diana, you mentioned prescriptive practice. What latitude do you have? In other words, what can you prescribe and what can you not prescribe? For instance, everybody would want to know about things like Vicodin and OxyContin, etc.
Well, that has evolved too, because when I first got my prescriptive authority, I was not allowed to prescribe Schedule IIs. Currently at the gastro clinic that I work at with, Dr. Fahmy and them have chose that I do not prescribe Schedule IIs, but I do them all the time for my nursing home patients. So I really, as long as I have this document called a Standard Care Agreement on what I knowledgeably and educationally can do for these patients, and I don't step out of that bounds, I can pretty much prescribe what I feel comfortable and have the knowledge to prescribe. I would not go out and prescribe things for children because that's not my focus. I've always been adult health care, so I don't do any children. I don't prescribe things like Ritalin because I am not comfortable with that. I have not been trained in that. I haven't done anything extra with that. But
in the nursing home, that contract you signed or whatever, is that with supervision of some medical director or not?
no. No, I'm independent practice, so I bill to Medicare and Medicaid, to the insurance companies, and sometimes don't get paid for 4 to 6 months, but, you know, that's how it goes.
That's all separate from your GI job.
That's separate from my GI job. In GI, it's so exciting because there's so many things. I mean, you just think, you know, nausea, vomiting, diarrhea. No, I mean, we've got some very interesting things. We've got people living with Crohn's, ulcerative colitis. We've got people with pancreatic problems, cancer of the colon, just liver, heart. I mean, just so much is involved. And I like this one because you have kids, well, we don't see kids, but age 15 to 115, you know, you see everybody.
What's the difference between having a doctorate in nursing and being a medical doctor? As far as...
Yes. Again, there you need to know where your boundaries are and where your scope of practice is. So I would not, even to this day, you know, there are certain patients that I feel is much better seen by Dr. Fahmy, Shower, Canal. So those patients go to them. I do have my own patients. Darren has his own patients. They usually see us only.
Nurse practitioners, do they get involved with home health care too?
Yeah, you can, and schools, home health, and hospice. A couple of my friends are in hospice.
Any other questions? What about salary range?
Salary, this area seems to be flooded with a lot of nurse practitioners, so you're probably gonna be at the 80 to 90,000. You can go a little higher when you're in subspecialties. You get up towards Cleveland and Akron, you're talking 100, 110,000 a year. That's just base salary. There's so many other perks, you know, you've got your vacation, you've got your continuing education. You know, sometimes we have profit sharing where we work at, we have that. So it really depends on the contract that you choose to sign with the physician or group that you're, there's all advanced practice nurse groups in this area as well. They do mostly nursing homes. But that is something you would cross when you get to that point, you know, what you're gonna put in your contract, what you're gonna ask for.
If you have 2 full-time jobs, you're not very lazy, right?
No,
But you don't have any debt either.
I don't. Actually, I'm working on my kids' debt now.
I have a question. It may not be of interest to the student, but I'm curious. When you work independently as a nurse practitioner, I mean, it's a litigious society nowadays. Does the state help you with malpractice
No,
insurance?
I have to
No?
carry my own through an
Carry your own?
insurance company.
Not a group plan through the state or anything?
Our GI office group has a group plan that we're on, but I carry my own independent one when I'm at the nursing homes. That's another expense. I mean, there's a lot of things that you want to
How much a
negotiate.
year do you pay for liability coverage,
It is
roughly?
roughly about $1,100 a half, which is nothing when you talk about what physicians have to pay.
It's not bad.
It's a lot for me, so, but it's, you know.
Sure.
You know, and even your license, like I just had to renew my DEA license. I mean, that's an expense too. That was $900, so.
Is that for 3 years?
Yes, it is for 3 years this year. Yeah. So there's, you know, a lot of things that you can do with this, that you don't always have to stay direct hands-on with patients.
Okay. If there are no other questions, I'd like to give thanks to these 2 people. I missed the second half of the Morales.